Webinar, Dr. Shiloah Kviatkovsky, PhD, CISSN. Dr. Kviatkovsky is an assistant professor in the Department of Orthopedic Surgery at UAMS with a secondary appointment in physiology and cell biology. She began her academic journey at San Diego State University, earning her undergraduate degree in kinesiology, followed by a master's in nutrition and exercise physiology. After graduate school, she put her skills to work as a researcher for the United States Navy, focusing on optimizing performance and health in military special operations. Work that also introduced her to cognitive and psychological science through studies on blast exposure and brain injury. Dr. Kwiatkowski then went on to complete her PhD in exercise physiology at Florida State University, where her dissertation centered on collagen peptide supplementation and its effect on pain, physical function, and connective tissue remodeling. Today, her research zeroes in on nutritional interventions for connective tissue health, particularly collagen supplementation to improve recovery after injury and orthopedic surgery. Her work has been published widely, including in the Journal of the International Society of Sports Nutrition, Current Opinion in Clinical Nutrition and Metabolic Care, and the American Journal of Clinical Nutrition. Please join me in welcoming Dr. Shiloah Kwiatkowski as she shares her insights on the role of nutrition on recovery from injury and orthopedic surgery.
Thank you, everyone. Thanks for having me. All right, so let me make sure I know how to do this. All right. So a couple disclosures. I do not have any potential conflict of interest for this presentation specifically, but I have current and prior funding from PB Leiner and Nestle Health for some of my collagen research. And I also have and currently still do consult for PB Leiner, Nestle Health, and Bonafide Health. All right, so getting right into the meat of it. One problem that we're going to talk about immediately is chronic pain and injury. Believe it or not, it is one of the highest ranked leading causes of disability in the United States and globally. In fact, it's the leading cause of disability in 17 to 44-year-olds. Roughly 20 to 33% of the world's population suffers from pain related to musculoskeletal injuries. Additionally, complex activity limitations and disability are very prevalent due to chronic pain, with the leading cause being lower back pain, followed by knee pain and neck pain. And that amounts to approximately $600 billion annually in healthcare costs and lost wages from people not being able to go to work. And a funny story, speaking of pain and injuries, I'd like to tell you guys a little bit about myself in a quirky manner. Has anybody ever heard of the term research is me search? So my good friend and colleague, Dr. David Church, DC, he told me that once. I've never heard it. And it happens to be very true in my case. So AI helped me generate this, this picture. Originally, I wanted to be a veterinarian and work with exotic animals in, fun locations. But I was also a total fitness addict, and I started to suffer a lot of injuries. Kidding, not that serious injuries, but more like that, okay? And so as I kept getting injured, I started to care a lot more about how to reduce my own injuries and enhance my own performance. And so very selfishly, I decided to change my trajectory to exercise physiology and nutrition. And 20 plus years later, here I am still doing it. So hopefully the selfish pursuit is not in vain. So problem number 2, nutrition happens to be vastly overlooked, especially when it comes to injury maintenance, prevention, and then also with surgery. So the statement here I'm making is pre-injury and preoperative nutrition status is an important determinant of healing and surgical outcomes, yet malnutrition assessment is not a widely integrated component in the standard of care in most places. And so we're going to talk a little bit more about that. So nutrition matters. Roughly in orthopedic population specifically, according to the literature, which there's not a ton of it out there because it hasn't really been assessed that much, Up to 50% of orthopedic patients are malnourished. And so when we're talking about malnutrition, a lot of the times we are really focusing on protein energy malnutrition. So micronutrient deficiencies, we can't really speak that much on because it's a little bit harder to measure and takes a lot more time, energy, and money also to be able to do that. So, but looking at this figure right here, you can see that preoperative nutrition has a big impact on postoperative outcomes. So someone who's coming in with a normal amount of muscle mass when they go through surgery, which is a major catabolic event, they're still going to have mild to moderate muscle loss. And so with increased loss of muscle, your risk of morbidity and functional dependence and mortality increases as well. So someone who is already starting off with low muscle mass is going to be at risk of critical muscle loss when they go through some kind of stress like a major injury or surgical procedure. And just kind of driving that home a little bit more about how much it really matters. Preoperative nutritional status will pretty much determine your ability to tolerate that surgical stress, as we discussed, your ability to recover, your injury risk. So remember that your skeletal muscle is your reservoir for amino acids, and immune cells are made out of proteins. And so if you do not have enough amino acids in your reservoir to do all of the functions that protein needs to do in your body, which is to repair and then to also fight off infections, you are at much higher risk of developing infections. Rate of wound healing, length of hospital stay, et cetera. So all of these things are highly determined by your preoperative nutrition status. And that takes us to our learning objectives for today. So at the end of this talk today, you should be able to explain the metabolic demands of healing after a musculoskeletal injury and or orthopedic surgery, and describe how malnutrition and inadequate energy availability impair tissue repair, muscle retention, and immune function. How to evaluate the role of micronutrients and protein supplementation in supporting wound healing, muscle recovery, and connective tissue repair. You should be able to identify key micronutrients and bioactive compounds that influence inflammation, immune function, gut health, and tissue regeneration in surgical and injury recovery. Be able to differentiate nutrition strategies for specific populations, such as elderly people, athletes, someone who's obese, by considering anabolic resistance, inflammation, and their unique recovery demands. And then apply some of the clinical strategies for early nutrition screening intervention and use an interdisciplinary approach to collaborate with colleagues to optimize patient outcomes in both of these settings. All right, so metabolic demands of healing. Phases of healing, you guys have all probably gone over this, but we'll just kind of rehash it a little bit. You go through the ebb phase in the first 24 to 48 hours. This is your fight or flight response to stress. And so your body goes into kind of a store. Your metabolic rate decreases and you're trying to conserve energy. After that, you end up in a flow phase, which is the catabolic phase of that phase. And that can last days to weeks. You will have increased energy expenditure due to increased catecholamines and stress hormones. You will have an increase in mobilization of your energy stores, more fat breakdown, more muscle breakdown, elevations in glucose so that your brain will remain alive, and insulin resistance. Hopefully you can get out of that as quickly as possible and go then into the next phase, which is anabolic. This can take weeks to months, and this is where you start to recover and rebuild, and your metabolic rate normalizes, and you're able to start to work on replenishing your protein stores and to regain function. So clinical cues here would be some hemodynamic support, but then protein-sparing strategies when you're especially in that catabolic state, and then working on rehabilitation and nutrition. And this also is going to vary depending on the severity of the injury and then any comorbidities and your care. So when we're looking at normal metabolism in a non-stressed, non-malnourished person, we can see that at a normal metabolic rate, you're roughly expending about 25 to 30 kilograms per gram per day. You should be consuming about 55 to 60% of your calories from carbohydrates, 25 to 30% from fat, and then 5 to 10% from protein. You can see here that there's a normal cycle of just, use and demand. There's nothing really being stored unless you're consuming calories in excess, and that goes into fat storage. Hormones are in balance, your protein synthesis and breakdown is in a nice equilibrium, and it's doing what your body is supposed to do. But when we start looking at starvation, your body goes into more of a protective mode. Your metabolic rate decreases to roughly 20 to 25 calories per kilogram per day, and that can even lower depending on how long you've been in this state. Your energy from fat storage increases, and your energy from protein actually decreases. So you're not doing a whole lot of gluconeogenesis because your body is in a storage kind of mode where it's protecting itself. And so when you look at stress in comparison, now you're in that fight or flight stress response, you're looking at an increase in metabolic rate. So 35 to 40 kcals per kilogram per day, you're increasing your glucose production in excess of your needs because you want to elevate blood sugar. And you're not using fat for energy any longer. So imagine going from the prior state where you're at this conservation mode where you, to this mode where you are now completely destructing the little bit of muscle that you have. So that's kind of what I want you guys to think about when you're looking at the metabolic demands of stress. Just to drive home that point, when we're looking at wound healing, if your energy stores and your protein stores are depleted when you are trying to heal a wound, you will have a lot more catabolism, a lot less anabolism versus when you're in a optimal kind of nourished state. And so something like pre-nutrition emphasis could bring you to this point where you have an increase in anabolism and a decrease in catabolism when you're trying to heal a wound. So as I said, optimum nutrition is a well-established key factor in maintaining all phases of wound healing. Some other key concerns when someone's injured is immobilization and disuse. And so that generally leads to atrophy of muscle and then loss of strength. You're no longer providing a signal for protein synthesis. Movement is probably one of the best and key ways to be able to initiate protein synthesis other than consuming large quantities of protein. You can develop anabolic resistance, proteolysis, and then what happens after that, unless you're able to regain some of that muscle and strength back, is that you become more frail and you can actually develop a greater risk of fractures and falls. So key elements to really focus on are controlling your catabolic state and then restore someone to their macronutrient intake to meet their energy and protein needs. The current recommendations for protein to RDA is 0.8 grams per kilogram per day. So you would at minimum want to double that when somebody's in this state. And you'll see some recommendations in a little bit that even are larger than that. And then you would want to increase anabolic stimulation. You can do that with physical therapy and resistance training as tolerated, but also some of the protein timing can also enhance those effects. And what you really want to do is also avoid the regain of body weight as fat. You want to really emphasize getting lean body mass back, so skeletal muscle. And calculating energy needs, you would use basal metabolic rate times the stress factor, generally 1.2 to 1.5 in this population, and any kind of activity factor for them. And if someone comes in already malnourished and they've been losing weight, the recommendation is to increase their energy requirements by 50% of what this number would be. So a study looking at disuse atrophy due to immobilization, they looked at 7 days of immobilization between legs, and they compared leg extension, leg press, leg curl, and calf raises. And what they found was that post-immobilization, there were significant reductions in strength. So here you can see there's a significant reduction in strength in the same leg with leg extensions, leg press, and calf raises. And when you're looking at the percent change, there are significant changes in comparison to the non-immobilized leg. So 7 days shows you that that can have some significant declines in strength already. Additionally, they looked at thigh volume, quadricep volume, and hamstring volume, and they looked at 2 days and 7 days. This is the control leg. This is the immobilized leg. The white is 0 days out, 2 days out, and 7 days out. You can see here that the muscle volume in all 3 regions significantly decreased as early as 2 days, and then after 7 days, significantly lower again. So pretty dramatic. I'm going to look at the chat really quick because I see a couple of things in there. Okay, perfect. So nobody had a question. I'll wait till the end for that. So protein to the rescue, right? So we're focusing a lot on lean body mass, and so it makes sense that we would talk about how protein kind of falls in here. As I stated before, our skeletal muscle is our protein reservoir or our amino acid reservoir, similar to bone being our reservoir for calcium in our body. And so when we need to increase amino acids in our blood, if we are not consuming them, then that is where our body can get them from, in addition to also utilizing some of those amino acids to make glucose. So you can see here in a nice unstressed state, there's kind of a normal efflux of amino acids into into the blood. And it's kind of evenly distributed across the body into the different regions. But in a state of stress, we have an increase in efflux from that skeletal muscle, which then is redistributing those amino acids to where they are most needed. And that would be to the area where there is a wound, to immune cells, and then also to the liver to help with elevating blood glucose through gluconeogenesis. So protein is fundamental. Protein supplementation supports muscle retention, wound healing, and immune response. Here we see that recommendation, a minimum of 1.6 grams per kilogram per day, up to 2.2. And so that really depends on the person and the situation. Emphasis is on leucine-rich protein sources, things that have complete proteins, so a complete essential amino acid profile. And you can see that here in this figure. So when we're looking at pre-surgical nutrition as we get closer to actual surgery, you look at animal sources of protein, they tend to be more complete. And so that's going to give you the more optimal amino acid profile in comparison to plant foods. You'd have to eat substantially more of these to be able to get that similar amount of protein. But as you get closer to surgery, recommendation is to start to use something like a whey protein powder, something that's easily digested. And then if not fasting prior to your surgery, to then consume essential amino acids prior to and then post-surgery. And then to slowly incorporate these back in. You want something that's faster digesting when you're getting closer to going into a procedure. And so these are more broken down. And again, you're just going to have a more rich and complete amino acid profile, especially of the essential amino acids as you're up here, rather than just a plant protein or just taking branched chain amino acids, since that's just 3 of the essential amino acids. And to revisit some of the roles of amino acids in healing, so we have 9 essential amino acids, and a lot of them are, obviously all of them are critical, and we use these to make our non-essential amino acids. Leucine, like we said, is very important in muscle protein synthesis, but a lot of these amino acids are. The one that I want to really highlight here, glycine and proline, in times of high stress and injury, they can be considered conditionally essential as well, because we have an increased need for them. And they also happen to be major constituents of connective tissue. And so that's something that you'll see in collagen supplements a lot too. We'll get into that a little bit later, but I kind of just wanted to highlight these here. And that takes us to essential amino acid supplementation. So I did mention them. I don't know if anybody's familiar with them. I think most people have heard of branched chain amino acids and whey protein, but not a lot of people are familiar with the fact that you can supplement with an actual product that is just made up of essential amino acids. And there have been some remarkable studies actually by Bob Wolf and Arnie Ferrando and David Church here. They kind of pioneered some of this data, but this study by Hans Dreyer, is the one I'm going to look at because it's in total knee arthroplasty. So what they looked at was 1 week of preoperative supplementation and 2 weeks of postoperative supplementation with essential amino acids compared to a placebo. And they gave them 20 grams of essential amino acids twice a day, so in between meals, and they compared that to the placebo. And what they found were that there were significant improvements in both the operated quadricep and non-operated quadricep in that EAA group when they looked at muscle volume with MRI. And they saw similar results in hamstrings as well. So what they were able to see is that just 1 week of pre-supplementation and 2 weeks of post-supplementation with EAAs enhanced the muscle volume, or at least was protective of it. Additionally, they found that some of the functional measures they looked at were also significantly better in that EAA supplementation group. So these people were able to recover faster when they took EAAs, which obviously probably spared the loss of muscle and also the loss of strength, and allowed them to regain strength faster as well. So collagen, something that I've worked with. I am not referencing one of my own slides. I'm referencing this landmark slide study that was done in 2017. They looked at 15 grams of collagen with 50 milligrams of vitamin C. So vitamin C allows for collagen to be produced. And so a lot of the times vitamin C status can actually really determine whether or not a collagen supplement will work, let alone if just you're able to repair collagen in your body. It's especially relevant for tendon and ligament recovery, also bone. So a lot of your bone is made out of collagen. And the three main amino acids, especially in type 1 and type 3 collagen, are glycine, proline, hydroxyproline. And so especially in supplements, you'll see those as individual amino acids, but you'll also see them as di and tri and even larger peptides that are thought to have bioactive properties. So signaling properties, but then also providing the building blocks for recovery. And so they saw that there was kind of a dose response here with the product. So 15 grams a day, enhanced connective tissue repair. And one of the recommendations would be, and this hasn't actually been tested, but they're seeing in some of the studies where they're looking at just the appearance, rate of appearance of those amino acids and those peptides, is that they kind of peak roughly around 1 hour post-consumption. Additionally, with connective tissue, there's not a lot of blood flow into that tissue. And so one of the biggest stimuli of that tissue for repair and turnover is actually exercise and stress. And so it's kind of intuitive to say that if you really want to enhance the potential of taking a collagen supplement to help you with recovery, that you'd probably take it about 60 to 90 minutes before you go and you do your rehab. And a lot of the studies that look at collagen supplementation with rehab actually are the ones that they've seen the most improvements with, rather than no exercise at all. So yeah. Yeah, on engineered ligaments. Yeah. And they saw that the 15 was significant. And with collagen, it's also kind of, this is an immediate response versus long-term responses. So there are some studies that have been, over the course of a year with 5 grams that have had benefits on bone mineral density. And so it kind of depends on the product. But yeah, this study showed 15. My studies have shown 10. So more is not always better necessarily. Good question. All right, so just to summarize our protein section, focus on improving preoperative nutrition. So like I said, prehab. I have a good friend and colleague who went in for arthroplasty surgery. He's in his 60s, and I saw him the day of his surgery, and he had definitely put on at least 5 to 10 pounds of muscle before I saw him. And he happens to have an expertise in this area, and so he trained up to go into his procedure, and he had the most miraculous recovery process I've ever seen. Probably he wanted to go out and exercise before his surgeon was ready for him to go out. And so this whole idea of prehab really can impact recovery outcomes. I'm very certain of that. So I think that that's something that we should start to really emphasize and focus on, and people should maybe pay a little bit more attention to that. And that wasn't just working out, that was also increasing nutrition intake. It was also enhancing, EAAs and protein intake as well. Underfeeding is a common problem postoperatively, so that's something that needs to be kind of emphasized as well. And because the caloric deficit will lead to impaired healing and sarcopenia potentially, and then we talked about frailty and fall risk and more fractures. So some of the recommendations, 7 to 10 days before any type of procedure, that you want to really, really emphasize whole food nutrition, 30 grams a day, 30 grams per meal of protein, snacks. You want to really make sure that they're eating good, healthy, quality carbohydrates. And then 12 hours before, having a good meal with 30 grams of protein, well-balanced meal. And then again, if able to, 6 hours before, having 30 grams of protein from potentially a whey protein supplement, and then 50 grams of carbohydrate and 12 grams of EAAs 2 to 4 hours before, if allowed. And then postoperatively, you would want to kind of reverse that order. So as soon as they're able to tolerate it, you want to give them some EAAs and some easily digested carbohydrates, then kind of move on to something like a whey protein with 30 grams of protein 24 hours after, unless they can eat or tolerate foods after an actual meal. And you'll see here that there's some additional protein that is being recommended. So remember those recommendations of 1.6 to 2.2 grams per kilogram per day. That's a lot of protein. And so a lot of people have a hard time eating that much protein from whole food sources. So supplementation is almost, inevitable. And then even days after, continuing to eat really good quality food with a lot of nutrition and continuing to increase protein supplementation. So that takes us to micronutrients. And yeah.
Talking about this recently.
Mhm.
So I'm wondering, do you guys have a guide for how that might be adjusted with weight? Like a 300-pound person versus 100 pounds? Like, do you do an adjustment factor for that 1.6?
So
Do you like actual weight?
yeah, so you would do by per kilogram per gram, but I think you'd also want to look at, what their other status is and determine whether or not. So I think at minimum, you'd want to double it. That's been shown to be able to preserve lean muscle mass. But, if somebody is 300 pounds, that 2.2 is going to be very hard to achieve. And so sometimes you can just kind of, those EAAs, that's where they really come into play as well, because they don't actually have any kind of filling effect. So, you can drink that in your water and it has minimal flavor. They actually taste pretty good. It's like a flavored water. And so that way you're able to get those amino acids in, and that's not impacting your gut like it would be if you're having a shake, every couple of hours. So, I mean, it's a good question. And there are definitely different recommendations specifically by each situation. So I'll just go into the literature and look at that. But yeah.
Most findings, you think it's going to be better from the target specific protein? Should or bed, should I be loading up as much as possible at first thing in the morning? But what's the best time to
So I think distributing them evenly throughout the day is probably going to have the best effect. There is pre-sleep protein research out there that shows that there is enhanced recovery if you do a bolus of protein prior to going to sleep, because that's the best time to recover. So that's an excellent question. I would say for this population, you probably don't want to go with casein. You'd probably just want to make sure that they're having their whey protein. I know a lot of athletes take casein or a mixture of casein and whey prior to bed. And they've seen enhanced recovery also with more carbohydrate a little bit in that mixture. So there is a lot of literature out there. I don't know how much data there is though in clinical populations. My PhD advisor, Mike Ormsby, actually has done a lot of that pre-sleep protein feeding and carbohydrate feeding research. And so he might know a little bit more. I could always reach out and follow back with you guys on that, but I haven't seen it necessarily in that clinical population. So it's an excellent question. Yeah. I'm sorry. Yeah, so I mean, there's some literature out there that show that if you consume 30 or 40 grams before bed, that it enhances recovery, but a lot of that is in athletes. And so it just kind of helps them with muscle recovery. And some of those also have carbohydrates added to them. So it's not just protein. Carbohydrates before bed with protein also has a beneficial effect. So I don't know what has been done in these populations though. So I would definitely say that it makes sense that, if they take something before bed, and then generally you want to take something first thing in the morning and then just spread it out throughout the day. Yeah, you could have a whole food meal, but I mean, again, some people really struggle to get their protein requirements in, especially when we're talking about older populations who kind of, intake is a major concern for them. And so shakes are probably the best way to go about doing that. Yeah, these are great questions. Yeah. Well, I'll have some Q&A at the end and you guys can come talk to me afterwards as well. I'm happy that you guys have so many questions. All right, so micronutrients and their friends. This study is actually a great study, something similar to what I'm doing now. It was done in lower limb trauma patients over the course of a year, and they just assessed their nutrition deficiencies, macro and micronutrients. And so I'm not going to focus on protein because we've already kind of gone there. But really interesting, they assessed almost almost 1,000 people, and they found that 75% were deficient in vitamin D of their trauma patients, 54% in vitamin C, zinc, 56%, and then vitamin A. So I highlighted those because those were the top 4, and they are really, really critical in healing. And so these people are not coming in for elective surgeries. This is just random people that had a traumatic event and had to come in for a procedure for their lower limbs. So this just gives you kind of a snapshot of the types of micronutrient deficiencies that everyday people are out there walking around with. And just to kind of drive home the message, when we're looking at the metabolic demands of healing in those different phases, you're seeing that, vitamin A is really critical in multiple phases here with inflammation, proliferation, remodeling. Vitamin C, remember, we need that for collagen synthesis. We need fatty acids, selenium, zinc, vitamin C and E, and all of those amino acids. So really important to also know whether or not somebody has these types of deficiencies as well. And the key would be to get people up to adequacy, not excess. So, nobody's going to have kind of enhanced effects from taking megadoses of anything. But what we want to do is restore normal, healthy values. And so an emphasis on vitamins and minerals for wound and bone healing, such as A and C for collagen synthesis, vitamin D, bone immune function, zinc for cellular repair, and calcium for bone remodeling. This is really, really tiny, but this was a review done for recommendations for pre and postoperative supplementation for plastic surgery. And again, they're recommending vitamin A, vitamin C, D, glutamine, arginine, omega-3 fatty acids, obviously protein, probiotics, and zinc. And so the big stars here seem to be that we really need to focus on at least making sure that people are in a healthy nutrition status for vitamin D, A, C, and zinc. Inflammation and nutrition. So omega-3 fatty acids are known to be anti-inflammatory, and they have been shown to preserve muscle mass, but really only effective in pre and post surgery. So this is a population that really could really benefit from those fatty acids, but you want to make sure that you're not introducing them when they're still in that inflammatory phase, because you want that inflammation. So there is a decrease in inflammation, and then there are questionable reductions in muscle protein breakdown and improvements in muscle protein synthesis. Again, vitamins A, C, and D. Limit high doses of any type of antioxidants early on and post-op, because you want to also avoid blunting that inflammatory signal, like I said. Gut health is a major factor in surgery, especially because of antibiotics, going under anesthesia, and then some of the opioids can disrupt the gut microbiome, and that will impact inflammation and nutrient absorption, and that can last for quite a long time. So taking probiotics prior to surgery and then continuing on afterwards. I've known some people that have gone through surgery and they've had major GI issues for several months after surgery. I have limited knowledge on this, but this is an interesting study and something I really didn't know about, but there happens to be a gut-bone axis. So if any of you guys are interested, this is your opportunity. You've heard it here to go down and dive deeper into that realm. So probiotics, prebiotics, and then when you're looking at certain populations, athletes may have higher needs because they are active. They're trying to also get back out there faster. However, they probably have a better nutrition status than somebody who's obese or elderly, unless they're kind of suffering from red S, and you'd be able to tell if they're like hyper lean. Obese people, they suffer from chronic inflammation. They generally have nutrient imbalances, tend to be malnourished as well because they're generally eating more energy-dense foods that are nutrient poor. There's sarcopenic obesity also, so they have poor muscle quality, poor muscle mass, and other comorbidities that impact them. And then elderly people who, especially for me, when I'm doing a lot of research with our joint arthroplasty surgeons, a lot of them are going to be in that aging older population. And so they have, anabolic resistance, deficiencies, especially vitamin D and other micronutrients. They have reduced intake. And so you really want to kind of focus especially on these populations that are more predisposed to have these nutrition risks, and you want to make sure you're assessing them. I found this really interesting. So this is in older adults who had hip fractures. They showed that when they're trying to achieve 1 gram of protein per kilogram of body weight per day, through diet alone, that they were only able to meet 50% of their energy needs and 80% of their protein requirements from whole foods. And considerable evidence supports the concept that supplemental protein or higher dietary protein intake by older people hospitalized for hip fracture could reduce their risk of complications, improve their bone mineral density, and reduce their rehabilitation time. And so again, that kind of speaks to that there seems to be a need for supplementation and some type of dietary interventions, not just whole foods aren't cutting it for these populations. There is also a link with bone mineral density and protein intake. So it looks like people with higher bone mineral density also consumed at least the RDA for protein. And so that's a strong link there that was very interesting for me to find. Practical strategies for clinicians before I run out of time. Only 1 out of 5 patients receives pre-op nutrition interventions. So not a great stat there. 2 out of 3. And so this is, I think, a lot of the research is either in cancer and GI surgery. There's not a ton done in orthopedic surgery yet, so I want to kind of improve that. Are malnourished at the time of surgery, so that's a lot. So 3 times greater risk of having a complication if malnourished at the time of surgery and 5 times more likely to die than well-nourished patients. Only 1 in 5 hospitals have a formal nutrition screening process. However, 3 out of 4 surgeons believe that pre-op nutrition delivery will reduce complications. So it seems like surgeons and doctors are on board. And for every $1 spent on nutrition therapy in hospitalized patients, the hospital saves $52. So it seems like a no-brainer to the hospital system to also start implementing that as standard of care. So practical strategies. First thing, screen for nutritional risks. There are a ton of assessments out there that are validated. So we have the GLIM guidelines, which are really good. They look at a phenotypic criteria and an etiologic criteria, and then they kind of stratify them according to risk. And so what they really want to look at is intake versus body composition and whether or not you are at risk. Here you can see, you can't really tell. You can't judge a book by its cover, just like BMI. You don't know what the body composition is. And nowadays, even body fat percent is not the best indicator because we have these other elements that we need to look at, like muscle quality, not just quantity, I guess. Initiate early nutrition, 24 to 48 hours at least, if not sooner. Collagen protein timing, and then collaborate with your dietitians and your rehab team. And when looking at body composition, there are a number of recommended ways to do it. I'm working with bioelectrical impedance. That is probably one of the most accessible and kind of easily deployable to the masses kind of ways to measure body composition. So to get them in clinic, they're not as expensive as, you know, a DEXA, for instance, and there's no X-ray involved. So you can just kind of do these assessments repeatedly without any kind of impact. Ultrasound tends to be a lot more expensive and more effective than something like calf circumference. Currently, we are doing a study at Tosh with the joint arthroplasty team where we're assessing our arthroplasty patients in pre-op for their nutrition status. So we're using a hand dynamometer to look at hand grip strength. So that's a good determinant of overall body strength. We're looking at BIA, and we're assessing phase angle, skeletal muscle index, and then we're using that skeletal muscle index with the grip strength to look at something called muscle quality index. And so those are all indices that we're working on validating in orthopedic populations to create normative values. And then we're trying to see which ones correlate the best with any kind of postoperative complications in an effort to really kind of start adopting those types of assessments into standard of care so that we know whether or not somebody needs to be seen and have some type of nutrition intervention prior to being scheduled. Another one is Onodera's prognostic index. So that looks at albumin and lymphocyte count, and that's able to stratify them into low, medium, and high risk categories as well. So that tells us a little bit more about protein status. But there are no agreed upon one kind of assessment is better than the other currently, especially with blood biomarkers. So that's one of the efforts that we're trying to do. Also in red, you see here, unknown how implants impact these values. So when muscle or other foreign material is placed into the body, that does impact BIA measurements, also DEXA measurements. And so we're working on validating some of that and seeing if there's some kind of correction value that we can put there to make sure that if somebody already has one hip and then you put in the other hip, that we are getting a value that we can kind of trust. And then we're also looking at their nutrition status with some of these different biomarkers. There are ARIS guidelines, enhanced recovery after surgery guidelines, and a lot of them really focus on pre and post nutrition support, assessment, working with a team of clinicians to kind of make it a collaborative effort. I'm really low on time, so I won't go into the details here. And that takes us back to our learning objectives. So hopefully after this talk, you guys can answer some of these questions about the metabolic demands of healing, the role of macronutrients, specifically, especially protein, some of the key micronutrients and other compounds that are important for recovery from these injuries and surgery, and some of the practical clinical strategies to be used to assess some of this, the stuff that we talked about today. And I like to kind of end on a quote here. So let food be thy medicine and medicine be thy food. So that was Hippocrates. And I think that in this case, it's really a true statement, right? So instead of using pharmacological interventions to fix something that's broken, how about we work on, you know, using nutrition and getting up to a healthy status so that we don't need to take things unnecessarily, because we're perfectly equipped to do that on our own. So again, take home message, nutrition is a modifiable health factor. Protein, essential amino acids, collagen, energy, and micronutrients matter. Recommendations are at least double of the RDA for this group. A, C, D, and zinc are really important. Omega-3s, probiotics, early and individualized care will result in better outcomes. Remember prehab, so that can have a huge impact. And keys to success, nutrition screening, so looking at surveys, body composition, strength, and blood biomarkers, and pre and post-op interventions for at-risk populations. And here is my contact information. So I do a lot of research, and so if anybody is interested in anything that I talked about today, feel free to reach out to me and we can discuss if you guys want to have some kind of you know, volunteer or rotation or anything along those lines. You guys are more than welcome to contact me, or if you guys have any further questions. And with that,
Great presentation.
thank you.
With the whey protein, as you know, there are 4 or 5 different types of whey protein. Complete hydrolyzed whey protein, medium, and also partially And so that it can make a difference on the recovery.
Mhm.
And with the aging population to have the highest number of the injury, I think that's, can you comment on that? Is there differences between those and for recovery?
I would say that anything that's the most broken down is going to be the most tolerated, especially in a population that really doesn't like to consume very much. So I would say something like an isolate would probably be better than something that's not. I think with these products, though, a lot of it's trial and error. A lot of people that try whey, even people that are younger in their 20s, a lot of people kind of have to try different brands, not necessarily how it's broken down, but some of it is just about how it's sweetened or, just the actual product itself. Some of them just get GI upset. So I think whatever tastes good and it's well tolerated that somebody is willing to take, I think that's the biggest hurdle. But then, yeah, just something that's more broken down, like an isolate, if they have the opportunity and they find a product that they like. That's a good question, though. That's something that, we hadn't really discussed, the different types of whey.
The differences on that notion for aging population versus younger generation?
I don't know because whey is pretty well absorbed as far as I know. I don't think that they've really looked at differences between those. I think when it comes down to protein powders, there's more research being done on plant versus animal sources of protein with absorption and synthesis and things like that. But I don't know of any studies that have really examined the different forms of whey specifically. That's a great question. I should probably know that. Thank you.
Supplementing collagen beneficial for preventing injury?
I believe it does, but there is no research that has been able to prove that. So, I mean, that's just going to be something that people can think anecdotally, maybe that, they feel that once they started supplementing, they stopped getting as hurt. I know, I've been supplementing with collagen probably on and off for the last 15 years or so. And so I have my reasons that I continue to supplement with it and why I ended up in that space. And so whether or not it has reduced my injury probably risk, I would like to think yes, because I am very, very active and I don't get injured as much as I used to when I was in my 20s. And so, but it could also have a lot of other factors. But yeah, I mean, potentially is something that people would want to take. I mean, people are taking it for anti-aging and, if you want to have the optimal environment in your body and you have, a good balance of nutrition in your body, then most likely your body's going to be able to kind of withstand some of those forces that maybe it wouldn't if you didn't take it. So it's a good question.
And if you have like a patient that would come in, let's say an orthopedic setting, there's more than one type of collagen. I'm recommending, does it matter? Is type 1, type 2, type 3 a blend? Is there any particular one that we're targeting?
So collagen research is in its infancy. Type 1 and type 3 are generally together in a supplement, and type 2 is generally more for cartilage. And it's really beneficial in osteoarthritis, whereas type 1 and type 3 is more, a lot of the research has been done in skin and connective tissue. And so there is no blend of those three as far as I know. But the blends and the way that they are manufacturing them, and I think the profile of the peptides that are in there probably are more going to be a determinant of what they're effective for and how effective they are. There are some companies that are making medical grade nutrition products, collagen products that are specifically tailored for certain kind of populations. And so as a clinician, those would be the ones that they would want to kind of probably recommend for their patients. I don't know if they're out to market yet or if they've had FDA approval yet, but I know that it's coming down the line. So when it comes to kind of the more commercially available ones, I think, they're probably very similar. One thing that people don't know about collagen is that there are only a handful of direct-to-business providers of collagen. And the ones that everyone's buying from stores, those are direct-to-consumer products that people are taking from those kind of master distributors, the different products that they're formulating, and then they're combining those into their own compounds and then selling them to the public, so.
There is one question online.
Okay.
If a person is overweight or obese, can you use adjusted body weight formula to determine protein amount?
Can you repeat that?
If a person is overweight or obese, can you use adjusted body weight formula to determine protein amount?
Are you saying as a percentage of their total calories?
Or just the recommended protein amount instead of going with just the 1.6 across the board? Would you adjust their weight if they're overweight or obese? I mean, use adjusted body weight formula.
I think this is where probably talking to a dietitian would be probably more appropriate, because that if depending on what percentage, that can end up being a lot versus, if you're going by body weight. So that's where you want to really tailor it specifically to the individual. And this is why clinicians have that expertise. That's a great question.
Curious about working it into the clinical flow, and specifically the pre-surgery supplementation. Is there like a sweet spot of like minimal supplementation window that we need to achieve? Has there been research done?
I don't think there has been. I think the couple studies with, protein is generally 1 to 2 weeks. I think it's kind of difficult because depending on the surgery, there aren't a lot of surgeries where there is going to be that long of a window. I have a study that's coming up that, we're going to give them supplements for 1 month prior to their procedure. And that's actually, that's going to be hard to recruit from because a lot of people get scheduled a lot sooner. But also, I think it depends on what their actual nutrition status is. So somebody that is really undernourished and has severe protein energy malnutrition, if you can hold off on giving them a surgery, just like any other kind of comorbidities, like some people that I talked to and pre-op, when I'm consenting them for our study, they've told me that they've been waiting 2 years to be able to get cleared to be able to have the procedure because, they had other medical issues that they were dealing with. And so I think when it comes to nutrition status, that's also something that can be, it should kind of determine the length of time you need to wait. So if somebody's not healthy enough to have that surgery, then, that's the length of time that it should take to schedule them if appropriate, I guess. And that's what their provider can determine too, is, how much time do they have and how much can they tolerate waiting to be able to get to, hopefully a better status. So it's a great question. I don't know if they would go by that, but I think that some of the criteria that we're kind of evaluating now, I think some of those might be better indicators. So I think and probably not just one thing, it would probably be a combination of things, just like the GLIM, they kind of risk stratify you. So I think just kind of validating more of those measures for specific surgical populations and determining which ones are the best predictors of any type of, complications afterwards. And so if somebody's in, a high risk category, then you would just state that like, okay, we are going to wait until they're in this category and they achieve these values prior to scheduling. And I think that that's probably what some places are already doing. But I think that would probably be, something that we should try to strive to achieve once we get more concrete values that we can really trust that are good indicators of whether or not somebody needs to have that support. Yeah. Excellent questions.
So many different strains of probiotics. Is there anything in particular that we should be having our patients or ourselves just look for when we're going shopping in the supermarket for a probiotic?
So that is a very difficult question for me to answer because that is not my space, but it's an excellent question. So that's why I've just briefly
Like not for a particular company, but just for
the strains.
Just
Yeah.
So if it doesn't matter, what particular strain? there research into that? You said.
I'm sure there are, I'm sure there's research, but again, I think with also the microbiome, there's a ton of research, but it's also very, very like in its infancy. And they're seeing fluctuations, daily in gut health. And so that would be probably answered better by somebody else because I'm really not in that space at all. But it's something that everybody wonders because you just don't know. So as far as,
Microbiome of the individual, so they have different. So I think that's the problem. You're talking about 1 billion gut microbiota versus appeals that so I think that's
yeah. One thing you could suggest though is recommending foods that are healthy for the microbiome that they can feed off of because they need food too. And so establishing a healthy gut, really you can do that with a lot of fiber and all the foods that they like to eat.
There is one more question online regarding no omega-3s in early post-op. What is defined as early post-op in order to not impact the needed aspects of early inflammation?
And again, I think that would be just kind of case by case and the clinician would be the one that makes that determination. So yeah, not my area of expertise with the omega-3s, but that's something that would be something that you want to definitely take into account. Yeah, great question.
Is there any evidence on sex differences in terms of who's at higher risk for surgical complications, including investment?
I don't know. So, I mean, every time I think that there's another paper that shows me that there's not. Currently, I am kind of doing a retrospective study on the last 3 years of arthroplasty. And if you ask me again, when I've looked at that data set, I can tell you if there is, females over males or if it's pretty similar. I think when we looked at 1 year's worth, at least in between knee, hip, and shoulder arthroplasties, we saw that they were pretty equivalent. And so, but, as we increase our number, maybe we'll see some differences. But yeah, there's so many impacting variables there with age, bone mineral density, muscle. If you're going to look at maybe, I don't think we had enough people to look at, how being postmenopausal would impact that. But then again, if they're all in their 70s, they all kind of even out. So I think that there may be some differences between different pockets of ages, probably between like maybe 55 and 70. I would predict that there might be some, I don't know, with complications, maybe not, but I think with recovery, it might be more of an issue with females potentially just because of menopause. But again, we don't know that yet. So, and I haven't seen that anywhere in the literature yet. That's a great question.
We did disuse atrophy experiments. We saw that this kind of comes with your graph where you said disuse.
Yeah.
Atrophy. We saw that atrophy actually was more stark in female mice.
Uh-huh.
But if you looked at their muscle quality, the mitochondrial network, it was way longer protected than the male.
Interesting.
So,
Yeah.
typically, they seem to be doing worse. On a systemic level, they seem to be more protected.
Interesting.
That just kind of in the clinical population, we saw something similar.
And were they overactimized at all, or did you guys look at how sex hormones played a part in that?
They specifically looked at sex.
Okay.
differences.
Oh, yeah, yeah. So that's the thing where I would think that maybe because they do become kind of anabolic resistant after menopause. So I think that the sex hormones might have more of an impact on recovery just in that kind of little pocket of age, potentially when compared to males until males kind of even out with reductions in sex hormones. But again, I don't know. This is just my hypothesis, bless you. So any other questions? Excellent questions. Thank you for being so engaging. Yeah, thank you.